All right, so today's session is on diseases of the aorta. Uh, we're gonna we're gonna look at the normal aorta, the different components of the aorta. Then we're gonna look at the diseases affecting the aorta, such as aortic aneurysm, aortic dissection, sinus of Valsalva aneurysm, coarctation of the aorta, and Marfan syndrome. All right, so a few a few things about the aorta. The aorta is the largest artery in the body, and as you can recall, the aorta starts at the aortic valve. So it starts at the aortic valve, which comes out of the left ventricle, and it travels all the way to the abdomen. If you remember, just as you move from the aortic valve, you have the aortic root. Okay, the sinus of Valsalva are right there. Then you have the sinotubular junction. You have the ascending aorta. You have the aortic arch, the descending aorta. That's the descending thoracic aorta. Then you have the abdominal aorta, and then the aorta divides into a right and left common iliac arteries. The normal size of the aorta is about 2.5 to 3.5 centimeters. Okay, anything above 3.5, we talk about aneurysm. So aneurysm is actually a dilatation of a vessel. So this is what the aorta looks like. So again, the aortic valve, as you get outside of the left ventricle outflow tract, and then you have the aortic valve, you have the sinus of Valsalva, the aortic root, then the ascending aorta, the aortic arch, the descending thoracic aorta, then you have the abdominal aorta. When the aorta passes through the diaphragm and goes down, that's what we call the abdominal aorta. Then the abdominal aorta continues downward. Then you have the common iliac arteries. You have the right and the left common iliac arteries. So this is what the aorta looks like. You have to know the vessels that comes off the arch. So you have to familiarize yourself with the blood vessel that comes off the aortic arch. The first one is what we call the innominate artery, and the innominate artery divides into the right subclavian artery and the right common carotid artery. This blood vessel in the middle is the left common carotid artery, okay, and this one at the end over here is the left subclavian artery. This is the usual anatomy in humans. Okay, so you have to know the the aorta in depth. You have to know the branches, and you have to know the different segments. And what we mean by that is ascending aorta, the arch, descending aorta, that type of thing. So the diseases that can affect the aorta includes aortic aneurysm. Again, aneurysm is just a dilatation of the blood vessel, an abnormal dilatation of the blood vessels. And when we say dissection, aortic dissection, there's a tear in the wall of the aorta. That's what dissection means. There's a tear in the wall. Sinus of Valsalva aneurysm. So right where you have the sinuses, it's abnormally enlarged. Okay. Aortic coarctation. Coarctation is a narrowing, and you usually have this narrowing in the vicinity of the left subclavian artery. So I just showed you where the left subclavian artery is. When you have coarctation, that's the area that you normally have your coarctation. And then we talk about atherosclerosis. The aorta is subjected to atherosclerosis. Atherosclerosis is when you have a plaque. Remember that these plaques inside the blood vessels, cholesterol plaques, okay? What usually happens is once you have risk factors for coronary artery disease, high blood pressure, you're diabetic, you smoke, you have a family history of coronary artery disease. These things set up the right condition for the wall of the blood vessels to, to, to get impregnated with the bad cholesterol. So the bad cholesterol goes into the wall of the blood vessel, in this case, the aorta, and then you have plaque formation. Okay, that's what we call atherosclerosis. And then Marfan syndrome. These are, it's individuals with distinctive phenotypic features. They look very distinctive, very long wingspans. That is, their arms are very, very long. They tend to be taller individuals. They'll have what we call scoliosis. That is a curvature of the spine. And they tend to have aortic aneurysm in the ascending aorta, and they can have dissection. So this is a distinctive group of individuals that you have to be aware of. Other diseases that affect the aorta, Ehlers-Danlos syndrome. You must have seen these patients, we call them, you say that they're double jointed. They can twist in all sort of shape, twist and fit in a small box or a small area. They usually have what we call Ehlers-Danlos syndromes. The joints are very, very lax. These individuals also have aortic, they tend to have an aneurysm of the aorta, ascending aorta. Abscess, aortic abscess. So if the patient, say, have a vegetation, endocarditis with a vegetation in the aortic valve, it can erodes the wall of the aorta, giving rise to abscess. Aortic ulcer and intraluminal hematoma. So you can get ulceration in the wall of the aorta and hematoma. Hematoma is just a collection of blood. So in the wall, you can have bleeding in the wall of the aorta, giving rise to hematoma. And then transposition of the great vessels. When something is transposed, that means it's moved, it changed position. When we talk about transposition of the great vessels are the aorta and the pulmonary trunk. So those are the great vessels, the aorta and the pulmonary trunk. When we talk about transposition, they change place. Okay, so now the pulmonary trunk is going to come from the left side and the aorta is going to come from the right side. These are congenital problems. And when we do congenital heart disease, we'll go into that in a little bit more detail. And then aortic rupture, which is a real problem, especially in what we call deceleration injury. You involve in an high impact collision, you can have rupture of the aorta. So those things are important. It's very important to visualize, to look at the aorta in its entirety, especially if someone comes and you're looking, they come with signs and symptoms suggestive of aortic dissection. You have to look at the entire aorta. You can see the ascending aorta with your transthoracic echo. By just looking at your parasternal long axis view, you can see the aortic valve, you can see the aortic root, and the ascending aorta. So the transthoracic echo allows you to do that. You can also see the ascending aorta if you do transesophageal echo, and you put your at say 120 to 140 degrees using your multiplane TEE, you can see the aortic. You can see the left ventricular flow tract, the aortic valve, the aortic root, and the ascending aorta. Okay, so both the transthoracic and the transesophageal echo allow you to see that. In terms of looking at the aortic arch and the proximal portion of the descending aorta, you can use your transthoracic echo if you do your suprasternal notch view. So with the suprasternal notch view, with your transthoracic echo, you can see a little portion of the ascending aorta. You can see the arch and a small portion of the descending aorta. Your transesophageal echo, you can see all of that. With the transesophageal echo, you can see the ascending aorta, you can see your aortic arch and the descending aorta. So you have to know what modality will allow you to visualize which portion of the aorta. For the abdominal aorta, if you do your subcostal view, you can see the abdominal aorta, and you should get in the practice of looking at the abdominal aorta when you do your subcostal view. Okay. If you're looking at the distal portion of the descending aorta, the transesophageal echo is the way to go. You can't use your transthoracic echo to see the distal portion of the descending aorta. So if someone presents with aortic dissection, that is a rupture in the wall, they usually have this tearing, sharp, stabbing pain in the anterior chest that goes to the back, and they, probably they're hypertensive. They're usually hypertensive. You can't just use your transthoracic echo. You have to move on to your transesophageal echo to see the more distal portion, the lower portion of the descending aorta, because you cannot rule out dissection unless you can see the distal portion. All right. So again, to visualize the aorta, the parasternal, for the transthoracic echo, that is, you use your parasternal long axis view, suprasternal notch view, the apical long axis, and the 5-chamber view. These are views of the transthoracic echo that allow you to see portion of the aorta. However, the transthoracic echo will not allow you to see the aorta in its entirety. So you have to move on to the transesophageal echo if you want to see all portions of the aorta. The first disease state we're going to look at is aortic aneurysm. So for you to get aortic aneurysm, there have to be a weakness in the wall of the aorta, and then you get a bulging. You have a bulging and dilatation of that portion of the aorta. So first, the wall has to be weakened for you to get that condition. So this is what your normal aorta should looks like. And remember, we said the upper limit is about 3.5 centimeters. So this is what your aorta, normal aorta looks like. And again, remember, your aorta comes out of the left ventricle, it comes up the ascending aorta, the arch, and then the descending aorta. Once it passes through the diaphragm, then the lower portion is what we call the abdominal aorta. An aneurysm is a weakness in the wall of the aorta, and it bulges out. So this is what an aneurysm looks like. It bulges out. Okay? And there are different types of aortic aneurysm depending on where it's located. So there are different types depending on the location of the aneurysm. When we talk about thoracic aortic aneurysm, remember your thorax, or some people call it the chest, is that area which is above the diaphragm. So all the area above the diaphragm is what we call the thorax. So for thoracic aortic aneurysm, the aortic root, so that is why we measure the aortic root routinely to make sure that the patient don't have aortic root aneurysm or dilatation. Then you have the ascending aortic aneurysm just above the root. Then arch, where the aorta arches, you can have an aneurysm. And then in the descending aorta, you can also have aneurysm. You can have aneurysm in the abdominal aorta, abdominal aortic aneurysm. And you can have aneurysm not only in the abdominal aortic, but sometimes they coexist. You will have aneurysm in the thoracic aorta and also in the abdominal aorta. As a matter of fact, it's a commonplace for you to have aneurysm in the thoracic aorta and the abdominal aorta. So one of the recommendations is that if you find an aneurysm in the thoracic aorta, you should look for an aneurysm in the abdominal aorta, and vice versa. So if you find an abdominal aortic aneurysm, you should look for an aneurysm in your thoracic aorta. So this is a transthoracic echo parasternal long axis view, and by just looking at your image, you can see that, you know, if you're accustomed to doing a lot of echoes, you can see that the ascending aorta is a bit dilated, and not only that, but you have aortic insufficiency. Remember, if the root of the aorta is dilated, it's going to prevent the valve from coapting properly. Okay, so if you have a dilatation of the aortic root or the aorta, it's going to prevent proper coaptation of the leaflets, the aortic leaflets, and you will get leakage there. So when you measure this root, you can see it measures large, and then you measure further down in the ascending aorta, and it's large. Remember, the upper limit of the aortic root is about 3.7 centimeters. So you have dilatation all the way from the root going up. Okay? It's very important to measure, because the amount of dilatation will tell you if the patient need to have surgery, yes or no. Because one of the complications of dilatation of the aorta is rupture. Just like you have anything that's bulging out, it's a weakness in the wall, so the wall can rupture. And if it ruptures because of the nature of the vessel, and because it pumps so much blood, that patient can bleed out in a matter of minutes. So it's best to do surgery before it ruptures, because if it ruptures, very, very few patients will survive. Okay? So again, you have to do routine measurements. And as we had pointed out before, when you do, especially when you measure the aortic root, you have to say where you're measuring. Are you measuring sinus to sinus, or are you measuring at the sinotubular junction? You have to indicate what measurements are you doing, because the root, the root can be multiple things. So you have to indicate what measurement you're talking about. So this is a short axis view at the level of the aorta, and you can see that because it's dilated, the valves don't co-opt properly. You don't have proper coaptation. This is a 5-chamber view. Again, you can see that the aortic root and the ascending aorta is dilated, and you have aortic insufficiency, and you have your C-double of your aortic insufficiency, and you can quantify that. You look at your ejection fraction, you can see it's depressed. Okay, so you have to go through a routine study, but make sure you indicate, the size of the aorta, where you have the enlargement or dilatation. What are some of the causes for aortic aneurysm? What's the cause? All right, so the causes are multifactorial. However, the risk factors, these are conditions that can predispose one to aortic aneurysm: hypertension, high blood pressure, atherosclerosis, as we mentioned before, which the blood vessel wall becomes impregnated with cholesterol, and it becomes weakened, and it can dilate. Hypercholesterolemia, high cholesterol, tobacco use, okay, and Marfan syndrome. So Marfan syndrome, these individuals usually have a weakness in the wall of the aorta, and it dilates. Again, these individuals have distinctive features. They tend to be taller. The wingspan, which is the length of their arms, is much longer than the length of their body. And they tend to have scoliosis, that's curvature of the spine, and they tend to have problem with their eyes, with dislocated lens. Okay, those are some of the features of Marfan syndrome. Ehlers-Danlos type 4. Again, these are individuals who can twist themselves in all sort of position. We say that they're double jointed. Okay, they have laxity of the joints. Patients with bicuspid aortic valve tend to have a significant proportion of them will have aortic ascending aorta aneurysm. So patients with bicuspid aortic valve tend to have ascending aortic aneurysm. Patients with peripheral artery disease, because they tend to have atherosclerosis, they tend to have aortic aneurysm as well. And if you have elevated C-reactive protein, that's also a risk factor. What are some of the signs and symptoms of aortic aneurysm? How does patient present? What's the presentation? A lot of patients are going to come to the echo lab asymptomatic. That is, they don't have any symptoms related to the aortic aneurysm. They come to the echo lab for some other reason. Breast cancer, they need to have an echo prior to chemotherapy, or they have high blood pressure, or some other, problem not related to the aortic aneurysm. And then by you doing your routine measurements, and that is why you have to do measurements, you have to do routine measurements to pick up these asymptomatic patients, because the larger the aneurysm, the more likely it is to rupture. You want to do surgery before it ruptures. However, patients, because of the enlarged aneurysm, it can compress what we call the recurrent laryngeal nerve. That is a nerve that that will supply the vocal cords, and a lot of these patients will have hoarseness. So if they have aneurysm, usually in the ascending or the arch, aortic arch aneurysm, because of the enlargement, it compresses this nerve we call the recurrent laryngeal nerve, and they will have hoarseness. Patients with abdominal aortic aneurysm, because of the large, the swelling of the aorta, they can have abdominal and back pain. And because you have this outpouching in the wall of the aorta, blood can clot, and the clot can break off, and you get embolization. So these patients can present with strokes. They can present with, problem with the leg because a blood clot traveled to the leg. Again, with your transthoracic echo parasternal long axis view, you're going to measure the root, okay? But you have to state what you're measuring. Is it the sinotubular junction? Is it sinus to sinus? The sinuses are where you have the outpouching, so you can measure right there, or the sinotubular junction. The sinotubular junction is the junction where the sinus meets the ascending aorta. So that is that portion of the aorta where the sinus meets the ascending aorta. That's what we call a sinotubular junction. So you have to indicate where the measurements. The reason for that is if you go back and you're doing echo on that same patient, you know exactly where you measured. If someone else is doing it, they know exactly where you did your measurement. Again, with your transthoracic echo, you can look at the apical long axis or the apical three-chamber view, and you can see your left ventricular flow tract, you can see your aortic valve, you can see the root, and you can see the ascending aorta. With the five-chamber view, the same thing. You can see your left ventricular flow tract, the aortic valve, the aortic root, and a portion of the ascending aorta. Okay. With the suprasternal notch view, you can see a portion of the ascending aorta. The arch of the aorta is right there, and the descending aorta. It's very important to do this view because patients with, say, coarctation of the aorta or any other problem, aneurysm of the any portion of the aorta, you can see it. So you can do your measurements. Remember, the aorta should be less than 3.5 centimeters. Again, get in the habit of doing your subcostal view, looking at the abdominal aorta. Okay, you can pick up a lot of aneurysm there as well. With the transesophageal echo, uh, transesophageal echo is the modality of choice, the imaging modality of choice if you're looking, if you want to look at the entire aorta. If you want to look at all of the aorta, the transesophageal echo is the modality of choice, because with your transthoracic echo, you can't see all of the aorta. With your transesophageal echo, you can see the aortic root by your 120 to 150 degrees. You can see the ascending aorta, you can see the aortic arch, and you can see the descending aorta in its entirety. Okay? So this is a transesophageal echo. Once you see this off circular thing at the side, it's a transesophageal echo. And this is a long axis view. You spread the aorta out and you can look at the wall. You can do your measurements to see if there's any aneurysm. You can also look to see if there's any plaque on the wall. So transesophageal echo is very important. This is the short axis. Okay, this would be down in the descending aorta, way distal portion of descending aorta. And you can see, you can do measurements again. You can look at the wall to see if there's any plaque, any ulceration, anything, dissection as well. Okay, so how do you treat aortic aneurysm? So it depends on the size. So it's very important to do measurements. It depends on the size. If it's big and the patient have any symptoms, then you have to do surgery. If it's growing very, very quickly, you have to do surgery. If it's leak or rupture, then of course surgery. Okay. So when we talk about dissection, aortic dissection is when the wall of the aorta ruptures. There's a tear in the wall of the aorta. There are different layers in the wall of the aorta. We talk about the intima, the media, and the adventitia. So there are different layers in the aortic wall. And you usually get a tear in the intima, which is the inner portion of the wall. And then blood tracks in that middle layer and tear it apart. Okay? So that is what a dissection. So if this is the aorta, okay, so this is your so blood, the intima, blood penetrates the intima and enters the middle layer. So you have a tear in the wall. The blood enters the intima and rips and just continue to rip the wall of the aorta in two. What are the signs and symptoms? How patients are going to present. It depends, of course, on the location, where it is located. If it's in the, if it's the ascending aorta, they will complain of chest, and they'll complain mainly of chest pain, anterior chest pain, if it's the ascending aorta. If it's descending aorta, they will complain sometimes of chest, but mainly back pain. Okay, and they will tell you it feel like a rip, a sharp stabbing pain. Okay, if the dissection is in the abdominal aorta, then they will complain of abdominal or lower back pain. When you do your echo, if it's the ascending aorta or the aortic root, you can get pericardial effusion. Okay, because if you have dissection which goes way down into the aorta, that is ascending aorta, the aortic root, you can get pericardial effusion, and some of these patients will present with tamponade and death. So this is a surgical emergency. Patient can also present with congestive heart failure, strokes, because if the dissection moves up the aortic arch and nips off, say, the innominate or the common carotid, the patient can present with stroke, because remember, the common carotid divides into uh, internal and external carotid artery. The internal carotid artery goes to the brain, and if it closes off, the patient will present with a stroke. Peripheral neuropathy, because the blood supply to the nerves in the lower extremity and upper extremity comes from the aorta. So if it nips off these little blood vessels, you can have ischemia of the nerves, decreased blood flow to the nerves. So a patient is going to present with neuropathy. So when we talk about neuropathy, you talk about numbness, tingling, burning, pain. That's what neuropathy is, because of nerve problems. Paraplegia, for the same thing. The blood supply to the nerves in the lower extremity can be nipped off, so that the nerves die. So they will have loss of movement in the lower extremity. Okay, so there will be no movement, and of course numbness, tingling, burning, all of that type of thing. And they can also present with cardiac arrest. The blood vessel can rip completely through, and these patients can just bleed out and die. I will mention ischemia, so decreased blood flow to any area. Okay. There's a classification for aortic dissection. Um, you just have to know that there's a classification, and there are two classifications. One is what we call the DeBakey classification. With the DeBakey classification, we talk about the DeBakey type 1. It's DeBakey type 1 starts in the ascending aorta and it extends to the arch or beyond. So it starts at the ascending aorta and it may go all the way. Okay, this is the DeBakey type 1. These patients are usually treated with surgery. The reason for doing the classification is for treatment. So with your DeBakey 1, which starts in the ascending aorta and it extends to the arch, these patients need to be treated surgically. With type 2, it starts in the ascending aorta, but it doesn't go beyond that. These patients usually surgery as well. So anything that involves the ascending aorta is usually a surgical management. So DeBakey 1, which starts in the ascending aorta and go all the way around, or DeBakey 2, which starts in the ascending aorta and just stay there. These are surgical treatment, DeBakey type 1 and 2. DeBakey was a very famous cardiac surgeon from Houston. And then DeBakey 3, it starts at or just distal to the left subclavian. Okay, it starts at or just distal to the left subclavian. That is where you're going to find your ligamentum arteriosus. And these patients, type 3, are usually treated medically, just medicine. And then you have a Stanford classification, which is very similar. Your Stanford, yes, with Stanford, you have a type A and a type B. With your Stanford A, it starts in the ascending aorta. So your Stanford A includes your DeBakey type 1 and 2, which is surgical. So type A starts in the ascending aorta. With your with your Stanford B, it starts at or just distal to the left subclavian, which is where you're going to find your ligamentum arteriosus. And your Stanford B is usually medical treatment, usual medical treatment. So this is what your DeBakey, so this will be your DeBakey 1. Okay, it starts the ascending aorta, a rip in the wall, and it goes all the way down. So 60% of your patients are going to have your DeBakey 1, which is your So 60% of your patients are going to have DeBakey 1, and then this is DeBakey 2. It starts in the ascending aorta but stays there. So 10 to 15%. So these patients need surgery. Once it starts in the ascending aorta, surgery. And your DeBakey 1 and 2 is your Stanford A. So that's your Stanford A. Two different classification. And then your DeBakey 3, this is your left subclavian. It starts just distal, just beyond the left subclavian and goes down. This is your DeBakey 3 and your Stanford B. So usually medical treatment for those patients. So, you can evaluate these patients. You start with your transthoracic echo, but usually you will have to move on to your transesophageal echo because you cannot visualize the entire aorta with your transthoracic echo. So if you suspect aortic dissection, you have to move on to transesophageal echo. All right, so sinus of Valsalva aneurysm. So again, aneurysm is just an outpouching, an enlargement. So when you look at your sinuses, you have bulging of the aortic sinuses. It's more common for the right sinus to be aneurysmal in about 65 to 85% of the time. It's the right sinus. The non-coronary sinus in about 10 to 30%, and the left less than 5%. So majority of your sinus of Valsalva aneurysm involves the right sinus. So what are some of the causes of sinus of Valsalva aneurysm? Congenital. The patient, they're born with that. So it's just weak because there's a congenital problem and the wall is weak and it bulges out. Marfan syndrome. Marfan syndrome, the aneurysm is usually at the sinuses. So it is very distinctive. Patients with Marfan syndrome would have aneurysm of the sinuses. So you're going to have dilatation of the sinuses. Again, remember the Marfan syndrome patients, they have, their long wingspan, that is the length of the arms, is greater than their height. These are tall individuals. They have problem with the scoliosis, and they have visual problem. Loeys-Dietz syndrome can also have sinus of Valsalva aneurysm. Ehlers-Danlos syndrome, sinus of Valsalva aneurysm. And also atherosclerosis can also cause. Okay. Other causes for sinus of Valsalva aneurysm: syphilitic aortitis or syphilitic aortic problems. Okay. Syphilis, cystic medial necrosis. Okay. Trauma, chest trauma, and infective endocarditis, infection. So those are some of the causes. How does the patient present? Again, they may be completely asymptomatic. They come to the echo lab for some other reason, and you find that there's a sinus of Valsalva aneurysm. Or they can present with heart failure, because if the sinus ruptures, they can present with heart failure. When you listen, you'll get this continuous murmur, and when you put your hands on the chest, you get what we call a palpable thrill. It feels as if water is running under your hands. Now, coarctation of the aorta is very important because you will actually see patients with coarctation of the aorta. When we talk about coarctation, it's just a narrowing. Coarctation is a narrowing. So the aortic narrows in the region where you have the ductus arteriosus, or in the vicinity of the left subclavian artery. There's a narrowing right there. It is twice as common in boys as in girls. So it's more common in boys. However, it's common in girls with Turner syndrome. Individuals with Turner syndrome, so you have to, these patients are very classic. So you need to look at pictures of patients with Turner syndrome. Once you see one, you have seen them all. They tend to be of short stature. They have a web neck, okay? Short stature, web neck, mild mental impairment, okay? They cannot reproduce because of the abnormality, okay? All right. And we classify coarctation of the aorta into preductal, ductal, and postductal. The thing about the ductus arteriosus is right at the vicinity of the left subclavian. So if you want to use the left subclavian to classify it, that is fine. But we talk about preductal, that is just before the ductus arteriosus. There's a narrowing. Then ductal is right at the ductus, there's a narrowing. And then postductal is just after the ductus arteriosus. Remember, the ductus arteriosus is in the vicinity of the left subclavian. So this is what it looks like. So you have the ascending aorta, the aortic arch, and then once you get to the distal aorta, there's a narrowing, and there are different degrees of narrowing. Okay, it can be very, very narrowed or just a little bit of narrowing. Okay, this is what it looks like. Okay, so what are some of the signs and symptoms of coarctation of the aorta? Again, these patients may be totally asymptomatic, depends on how significant the obstruction is. But mild cases may have no signs or symptoms until later in life. So it depends on the degree of the obstruction. So other cardiac defects that is associated with coarctation of the aorta, and if I were you, I'd write this down and walk with it. Coarctation of the aorta is fairly common in patients with bicuspid aortic valve. If you see someone with bicuspid aortic valve, you have to look for coarctation of the aorta. They go hand in hand. And when you get any tests about bicuspid or coarctation of the aorta, they're going to ask you this. There's an association between coarctation of the aorta and bicuspid aortic valve. Sometimes you can get a VSD, you can get some mitral abnormality. If the coarctation is more than mild, you can get dyspnea, shortness of breath. Poor appetite if it's significant. Failure to thrive, that is, don't gain weight. Small individuals. Dizziness because of the increased pressure in the head and neck. Syncope because of the increased pressure in the head and neck. Chest pain. But the most important thing is that you'll get hypertension in the upper body because you have the obstruction right there. Everything above the obstruction, the pressure is going to be elevated. Okay? Patients are going to present with fatigue, headaches because of the increased pressure. Hypertension in the arms and a low blood pressure in the legs because you have an obstruction right at the descending aorta. So anything below the obstruction, the blood flow is going to be reduced, the pressure is going to be reduced. And we commonly talk about a radiofemoral delay. That is, if you check the radial pulse and the femoral pulse, the femoral pulse is going to be delayed because of the obstruction. So we talk about a radial femoral delay. Your echo is key though. The echo can clinch this diagnosis. Your echo can make this diagnosis. So when you look at your transthoracic 2D echo and Doppler, your parasternal, you can look at the high parasternal view, but the view that you want is your suprasternal notch view. Your suprasternal notch view, you're going to get classic features. So you have to know what your normal suprasternal notch view of the descending aorta looks like. Because once you see coarctation, it is classic. We talk about a sawtooth pattern, and you get color flow Doppler aliasing. So this is what your normal, your suprasternal notch view, you put your pulse wave Doppler there, and you get a systolic flow. It goes all the way back to the baseline. Systolic flow goes all the way back to the baseline. Systolic flow all the way back to the baseline. If the patient, however, have coarctation, it doesn't go to the baseline. You get this what we call a sawtooth pattern. Sawtooth pattern. Okay? It doesn't go all the way to the baseline. Okay? So there's a flow in diastole. Okay? Suprasternal notch view, your ascending aorta, aortic arch, and these are your arch vessel. Your left subclavian is right there. So your left subclavian is right there. Your left common carotid artery and the right will be someplace over there. Okay, you have a narrowing there. You put your Doppler. This is actually a continuous wave Doppler because the velocity may be elevated, so you'll have to use your continuous wave Doppler. Sawtooth pattern, classic. Okay, so if you do your C doubler, you get a sawtooth pattern. Once you see this, you have to think in terms of coarctation of the aorta. Remember what your normal suprasternal notch view of the descending aorta looks like. So once you see something looking like this, it's coarctation until proven otherwise. Remember, there's an association between coarctation of the aorta and bicuspid valve. Okay, you also have to know when you do your suprasternal notch view, you have to know this is your ascending aorta, the arch, and of course you have the arch vessels coming off. Your left subclavian would be somewhere right there. This is your left common carotid artery. This is your brachiocephalic or your innominate. This is your right pulmonary artery. Okay. All right, Marfan syndrome. So we've been talking about Marfan syndrome. Marfan syndrome, individuals tend to get aneurysm of the ascending aorta, mainly or aneurysm of the sinus of Valsalva. So they can get aneurysm of the ascending aorta. They can get dissection right there. Of course, these individuals they tend to they're born with a weakening of the media of the aorta, so the aortic wall is weakened, so it bulges out. And these Marfan syndrome individuals, in addition to have aortic regurgitation because of the aneurysm, they also will have some mitral valve prolapse, and you get you get thoracal lumbar scoliosis. You have a curvature of the spine, lordosis. So now the curvature of the spine. Okay. So Marfan syndrome is a connective tissue disorder. It's a problem with the connective tissue. It's an inherited condition, autosomal dominant, and the defect is in chromosome 15. You have a problem with the protein fibrillin. So it's a defect in the FBN1 gene on chromosome 15. Okay, the incidence is about 1 in 5,000 persons. Okay, your Marfan syndrome individual is going to have what we call pectus excavatum. That is, if you look at the sternum, the chest caves in. It caves in. Pectus excavatum. That's what that means. It caves in. Lens, they're going to have problem with the eyes. You have dislocation of the lens in the eye. They tend to have glaucoma, retinal detachment, visual loss, cataracts, blindness. This is what we call the Chen criteria. Okay, so that covers the aorta.